started our trial is whether the Goldman visual field would be a robust endpoint and visual acuity and functional MRI would be supportive measures. But what about other retinal sensitivity measures? What about combined treatments? The other thing is that we thought that we had a potential of identifying rapidly which patients will respond and where the dormant photoreceptors are. So I'm now ready to present to you the final results of our first 14 subjects with RPE65 or LRAD mutations, an open-labeled study where we treat the patient for 7 days and then stop. We treated 12 patients with 40 milligrams per meter squared per day for 7 days, and we treated 2 subjects with 10 milligrams per meter squared per day. We measured Goldman's, ETDRS acuities, OCT, functional MRI. We screened the patient twice before the drug, and on day 7, 9, and 14 after the treatment, and then almost every month. We also did full field ERGs and fundus autofluorescence. The entry criteria were simple: 2 mutations in LRAD or 2 mutations in RPE65, LCA with nystagmus. The mutations had to be confirmed twice, and the patients initially were between 5 and 14. Acuity had to be at least 2800 ETDRS, and no other eye diseases were allowed. For the Goldman visual field, we required 2 baseline results and a history of the patient knowing how to use the Goldman. And we then involved Ghislaine D'Angely from Johns Hopkins, who is a world expert at converting Goldman visual field size to retinal areas in a very well accepted method. And he's been doing all our analyses, so we don't do our own analyses. And we came up with a responder definition that more than 20% gain at 2 consecutive visits between 7 and 60 days constitutes a clinically significant and statistically significant improvement in Goldman visual field. The same way we looked at acuity at 4 meters and 1 meters, and a responder definition was more than 5 letters at 2 consecutive visits. Here are the results for the Goldman visual field. What we see here in the blue line and the lower line are patients with a relatively large 5-4E target at baseline, and we see that their improvement is halted by the what's called the ceiling effect. But patients with much worse disease, where the visual field was very small at the baseline, had a remarkable and rapid improvement in Goldman visual field size. And so now we're looking at all the patients, and we can see the percent change in log Goldman visual field retinal area is clinically and statistically significant, up to 30% improvement. And it's maintained for about a year, even though we treated the patients for 7 days. If we look at the data slightly differently, we take away the log and we only look at the percent change in retinal area, we see again the same trend that the worst patients had the best improvement. This is all the patients, the black line, and we see improvements of 150% in Goldman visual field size, maintained for at least a year, and then we see a decline. And we see that remarkable difference between patients that are severe and patients that are milder. We see the same thing for visual acuity, clinically meaningful improvements in visual acuity. And now I'll be quickly talking about some examples of some of the patients. Here's our first patient who rapidly improved in acuity from 2250 to 2100 and maintained it for 2 years. Her Goldman visual field immediately improved on day 7, doubled by day 14, and tripled by month 4. You can see that right here. And now, at 1 year, she starts to decline. Patient 5 had a relatively good OCT with thinning in the fovea and an abnormal autofluorescence and a very abnormal ERG. But despite this, she improved from 2250 to 2060 in 7 days and maintained it for 1 year. Her Goldman visual field illustrates the ceiling effect for the 5-4E target, but shows a remarkable improvement of the 2,4-E and 3,4-E isopters. Right here. This is before treatment, and this is after. Subject 5 reported that she can now see images on the small screen DVD player, able to watch the fireworks and see the stars in China, and can see movements in the dark. She can see white paper in the dark, and her father says she can see much better. Subject 8, we did another analysis. We converted the visual field to what the patient can see. So here is subject 8 with RP65 mutations on just before the drug and on the drug. Here is her visual field at screening on day 1, on day 7, on day 9, on day 14. In the 3rd month, her visual field is still enlarging. And then at 6 months, she starts to decline. 8 months, decline. 10 months. Her visual field improved in that way. Patient number 9 did not improve in visual acuity, but improved remarkably on the 2,4-E target, as you can see here. And we did a functional MRI before and after drug treatment for her, and we worked together with Dr. Mendola from the MNI at McGill. She's a world-leading expert in functional MRI. We showed many different targets, including face, houses, letters, and different moving objects. And what you can see here is a statistically significant improvement in functional MRI blood oxygen levels. On your left is her looking at faces before the treatment, and on your right is her looking at faces after the treatment, and she recruits a whole new visual area in the parietal cortex. And when you show her houses before and after the treatment, she lights up a much greater area of visual cortex. And we have one patient who did not respond to the drug, and the functional MRI correlates highly with that and shows no improvement. So she was able to see in the dark and more clearly and become more independent and can walk down the stairs and not use her cane. So in summary, 79% of our subjects, 11 out of 14, we call Goldman visual field responders. 43% of our patients are visual acuity responders. We have seen improvements in dark adaptation in daily tasks of living, such as inability to walk without a cane. We have seen that the therapy is well tolerated with transient headaches and photophobia. We have mild short-term reversible elevations in triglycerides and reduction in HDL, which return back to normal. So in conclusion, we have a positive proof of concept from this alternative retinoid, 9-cis-retinal. We have improvements in Goldman visual field area. We have improvements in visual acuity and cortical activity. And we have subjective assessment improvements that correlate. The drug is well tolerated with an acceptable safety. So in summary, we have now done 14 LCA patients in Montreal, and we've expanded to a 7-center trial and have now just completed 17 autosomal recessive RP patients with LRAT or RP65 mutations. And we have now completed our first autosomal dominant RP patient with RP65 mutations. So we've treated 32 patients to date. And we've seen significant improvements in Goldman visual field, acuity, and significant improvements in visual cortex activation. The improvements are rapid, they're robust, significant, and long-lasting. We have, just like the gene therapy group, shown that we have this remarkable population of dormant photoreceptors and the plasticity of the visual cortex despite lifelong visual impairment. The drug is safe and acceptable. We're now looking at longer duration and intermittent dosing of the drug. Repeat dosing is underway, and we are continuing to do repeat dosing in normal human volunteers. And we are ready to do a placebo-controlled pivotal trial using Goldman Visual Field retinal area as the primary endpoint in the design stages. This is a huge amount of work, and I would like to acknowledge all my co-authors, especially my group at the Children's Hospital, Janine Mendola, the QLT sponsor, Frans Kremers, who is always there to help me with the genetics, Anneke den Hollander, David Saperstein, Ghislaine D'Angely, Juliana Saloum, who sent a lot of patients, and Alan Bird, who's been our advisor. Thank you very much.